at UW in the neurology clinic at Montlake, as well as the rehab center at Montlake and the electrodiagnostic lab at UW. Dr. Distad earned her medical degree from the Medical College of Ohio, then did her residency training at the University of Colorado, followed by a fellowship in clinical neurophysiology at Stanford. She is actively involved in clinical research as well as medical education, and is a really fantastic sort of resource to have here in our community. She'll be speaking today on clinical trials and emerging therapies in myasthenia gravis. Dr. Distad, thank you so much for joining us today.
Absolutely. Thank you for having me. I'll go ahead and start sharing. Um, and do the slides look okay there?
That looks great. Thank you.
Great, thank you. And Kristen, thank you for the invitation. I really appreciate our collaboration. Um, and thank you for the opportunity to talk about myasthenia gravis today. There have been a lot of changes in the field. Sorry, trying to advance. Okay. So I am going to start with, I'm going to try to see if I can move the bar, which is covering my slides. So I want to talk a little bit about just some of the basics in myasthenia, the pathophysiology, and then move on to treatments, talking about our acute interventions, assessment tools, and then looking at what we've used over time and then what's newly available. And lastly, if there's time, I can touch a little bit on immune checkpoint inhibitor myasthenia. Sorry, still having trouble advancing slides. Um, so myasthenia gravis is an immune disease of the neuromuscular junction. We commonly see ptosis like the upper left. It is usually asymmetric over the course of an individual's life with myasthenia gravis. About 90% of people will have some ocular involvement, so that's a valuable piece. On the far right, we see very severe, an old picture of facial and jaw weakness. And in the middle is an individual where you can see at the bottom the asymmetric ptosis. And when the eyelids are lifted, you can see problems in adduction of the right eye, and the right eye is also down, and then also adduction of the left eye. And it's common to have multiple different cranial nerve abnormalities. Limb weakness occurs, it is usually more proximal. And weakness is fatigable, not fatigue, but fatigable weakness. So the more somebody exercises, typically the weaker they become. And shortness of breath may be an isolated presentation, so that's important to recognize as well. The autoimmune subtypes of myasthenia gravis involve commonly the acetylcholine receptor antibody, that's of the IgG4, IgG1, very important, and three subtypes. And the IgG1 is what activates complement. We'll talk more about that later. This is present in 80 to 90% of individuals with generalized myasthenia gravis. And there's an associated abnormality in the thymus, rarely thymoma, often lymphoid hyperplasia. And the bimodal distribution, younger women, older men, this is more common in women. The muscle-specific kinase antibody is an IgG4 subtype, does not activate complement, and it's present in about 5 to 10% of individuals with myasthenia gravis. There's no thymic association. Age of onset is variable, and it is much more common in females with more of a neck flexor weakness and respiratory involvement. LRP4 antibodies are not specific to myasthenia gravis, and when they occur with it, are present in about 1 to 2% of individuals. The age of onset is a little bit older. It also is more common in women. With antibodies in presentation, we often have an answer, and if not, we can support the diagnosis by doing repetitive nerve stimulation. In this scenario, this is a compound muscle action potential after exercise. 1 minute following exercise, there's a 35% decrease in the compound muscle action potential amplitude that naters at about the fourth or fifth CMAP, we call it for short. That is unique to neuromuscular junction abnormalities. Single fiber EMG is a more sensitive way to look for defects in the neuromuscular junction transmission, but it's not specific. And that involves these time-locked single fiber action potentials from a single motor unit. And when neuromuscular junction dysfunction occurs, we see a variability in the time between those time-locked single fiber action potentials, and that results in an increased jitter. And in significant cases, we see block of that transmission. This is nicely documented on electron microscopy. This is the axon terminal, and then we see these very efficient postsynaptic folds. When we're in myasthenia gravis, here's our axon, and you see significant disruption of those postsynaptic folds on the muscle membrane. So moving on to the meat of the talk about treatments, we have many potential targets affecting B and T cells, blocking acetylcholinesterase, altering complement or IgG. If we look back over time, this covers 60 years, starting with thymectomy used for myasthenia gravis in 1941, and then the addition of immune suppressant agents over time until we get up to eculizumab in 2017. And this slide, I will point out, is only 10 years, and we have 6 new agents to use in treating myasthenia gravis. What we've known over time with myasthenia is that if we increase the amount of acetylcholine with pyridostigmine or neostigmine or similar agents, individuals get improvement in their symptoms. Immune suppression, decreasing antibodies is effective. In more often crisis management, use of immune modulatory agents is effective. Despite all of these treatments, up to 15 to 20% of individuals have inadequately controlled disease. And this slide covers the typical agents that many use, including myself in particular. The regular dosing roughly, and then the side effects. So we have to monitor cell counts, liver function, and azathioprine. The bottom portion of this slide are other agents that have been used in myasthenia gravis and variably studied and regionally preferred. The other treatments that I'm just going to touch on are plasma exchange. This removes antibodies, removes solid factors. Response can occur within days or maybe weeks. 5 exchanges roughly covers the entire plasma volume of an individual, and risks may be related to central line placement if that's necessary, hypotension, and bleeding. In MuSK-MG, this is more effective than many other treatments. The response rate is similar to what we've seen in IVIG when compared in a trial. IVIG affects benefit in about 60 to 70% of individuals. It neutralizes antibody, alters the immune response. Dosing is 2 grams per kilogram. That's also considered a loading dose, and that's divided over 2 days or over 5 days. Headaches, myalgias are very common with this infusion, and renal failure I have not seen in decades, but I didn't want to I don't want to say decades because that gives away my age. So thrombosis, I have seen that, and may involve altering your treatment. IVIG we use in other autoimmune disorders, of course. And then aseptic meningitis can occur, and I've I've rarely seen that. That's typically related to the batch and does not recur. The 2016 publication of this randomized controlled trial of thymectomy in 126 individuals that were acetylcholine receptor antibody positive showed us that over 3 years there was improvement in the time-weighted average dose of prednisone as well as a QMG score. And this was significant at 12 months and sustained up to 3 years. Individuals had a significant reduction in their prednisone dose. The placebo group did not, and additionally, they required more rescue therapy and had more side effects from that. Just wanted to paint a little bit of a background of what assessment tools are used in these clinical trials. The MGADL score is something that's relatively easily administered in the clinic. And the higher the score, the worse the severity. This relies solely on patient history. And looking at these, what is considered clinically significant for an individual? Probably about a decrease in 2 to 3 points. When you look at this point by point, if we just selected the double vision, for example, a score of 3, constant double vision. If we just, if that was the only change, this individual may go to no double vision with a 3-point improvement, just to kind of put it in perspective. The quantitative myasthenia gravis score, or QMG score, relies solely on examination of the patient and covering a number of different areas of weakness that are common. The minimally important difference, clinically significant change for an individual, roughly around 3. For example, maybe they can't lift their head up at all. And then this is looking at, can they lift it up for a full 2 minutes, which takes something. That would be a significant improvement for most. The MG composite score was developed. It's more complicated, but was validated as being more valuable and higher correlation for individuals that experienced improvement in myasthenia gravis. This is a total score of up to 50, that being the most severe, and relies both on examination and patient history, with more weight on bulbar and generalized items. And a minimally important difference here was a decrease by 3 points, 3-point improvement. And then moving on to newer agents and clinical trials, talking about B-cell depleters, complement inhibitors, and FcRn blockers. So rituximab, I imagine most of you are familiar with this CD20 B-cell depleter. This was a unique study out of Europe in which they took 47 individuals that were early in the disease course, with the idea that this is before the effector cells start to perpetuate the mechanism by which there's damage to the postsynaptic membrane. They were treated with only a single dose of rituximab. And the primary endpoint was minimal disease, defined as a QMG score of 4 or less. The QMG score is the examination score. Prednisolone less than 10 milligrams per day, and no rescue required at 16 weeks. Of those treated with rituximab, 71% of individuals met this primary endpoint, compared to only 29% of the placebo group. And looking at the proportion of patients that had this minimal disease manifestation at each visit, the benefit was sustained out to 48 weeks. Rituximab was also evaluated in another phase 2 trial. This was a non-superiority design of 50 individuals. The treatment was more of the standard that's been used in autoimmune neurological disorders, and that is 375 milligrams per meter squared weekly times 4, and then this was repeated at 6 months. The primary endpoint here was a greater than 75% reduction in prednisone, comparing the baseline 4 weeks to the final 4 weeks of the trial. This was not significant, where there was a 60% mean reduction in the prednisone dose in those that were treated. There was a mean 56% reduction in the prednisone dose in those in the placebo arm. The Christmas tree plots do favor the rituximab treated group over placebo, but this was not significant. And I want to mention this trial in rituximab because in MuSK MG, because we have limited data based on the rarity of this antibody presentation. This was a multi-center blinded prospective review, and it looked at the primary endpoint of the myasthenia gravis status and treatment intensity. In myasthenia gravis, individuals are on multiple agents, some of them, not all of them. And this combined a post-intervention status with the number and also the dosages of other immune suppressant agents. And the lower the level, the 0 here, the better the patient was doing and the lower doses of multiple agents. And in the group that was treated with the rituximab, there were 42% of individuals that were in this 0 category, as opposed to more severe patients with a value of 6. And also in the, I'm sorry, I was distracted by my cat. I got off topic. In the control group, there were no individuals that improved to a level of 4. Also, at the last visit, 29% of the rituximab treated group were taking prednisone at a lower dose compared to 74% of the individuals that were not treated. Moving on to complement inhibitors. We know that the antibodies will stimulate activation of the complement cascade, and this activates the membrane attack complex, and this is what is responsible largely to the inflammation and the complement-mediated damage that occurs at the muscle membrane in myasthenia gravis. Terminal complement inhibitors as a treatment will block the cleavage of C5 to C5a and B, thereby reducing the activation of the membrane attack complex and therefore reducing damage to the postsynaptic membrane. Because the membrane attack complex is vital in bactericidal impact of the immune system against encapsulated bacteria, vaccination is required in use of complement inhibitors, and recommendations by the Advisory Committee of Immunization Practices, the ACIP, require that vaccination for both the MenACWY, which is 2 vaccines, and also against meningococcal B, which is 3 vaccines now, baseline 2 months and 6 months, and then boosters are also required. So that is a 6-month period and 5 vaccines to use these complement inhibitors unless you want to manage antibiotics for them during that 6-month period until the vaccines are taken. So eculizumab is a monoclonal antibody to C5, the first newer approved agent for myasthenia gravis. Enrolled 126 individuals. This was a phase 3 trial of refractory generalized MG, and that included an MG-ADL score of greater than or equal to 6, and individuals also needed to be on 2 immune suppressant agents. Dosing was ultimately every 2 weeks IV of eculizumab, and the primary objective was a change in the MG-ADL over 26 weeks by worst rank and COVA. This was not significant. Secondary objectives included a change in the QMG score by 26 weeks, also by worst rank ANCOVA, not significant. Looking at responder analysis for both MG-ADL and the QMG, there was a higher proportion of patients that had a clinically meaningful response that was defined as an improvement of at least 3 in the MG-ADL or at least 5 in the QMG score. And based on repeated measures analysis, this was approved by the FDA for treatment of generalized myasthenia gravis that was AChR positive. Ravulizumab is the newer version of that, also monoclonal antibody to C5. In this phase 3 trial, the dosing is weight-based and ultimately every 8 weeks, and looked at over 26 weeks the change in the MG-ADL. And this was statistically significant. The bottom line, ravulizumab, our top line is the placebo, both for the MG-ADL as well as the QMG score. These were pre-specified endpoints here of at least an improvement of 3 for the MG-ADL and an improvement of 5 for the QMG score. And both of these agents are FDA approved for treatment. Zilucoplan is the last complement inhibitor. This is a small peptide, binds to C5. This phase 3 trial involves a weight-based dosing daily, and it's subcutaneous. And the primary objective here that was met and significant was a change in the MG-ADL score over 12 weeks. There was improvement also in the MG composite. That was the more complicated scale that involved both examination and history. And this slide, it's reversed, so placebo is on this side and the treatment arm is on the right side. And for both these scales, there was a minimally clinically important difference. An improvement in the MG-ADL score of 2.1 points. Eculizumab was looked at in adolescents. This was only 11 individuals, and this was a phase 3 open trial over 26 weeks, and it was weight-based. There was an improvement from baseline in treated individuals of 5.8 points on the QMG score, and the commonly used and primary endpoint in many of these trials, the MG-ADL score, saw an improvement of 2.3 points. So all of these agents have been approved for treatment in myasthenia gravis. And then putting everything on one slide, these are the top are the monoclonal antibodies. Eculizumab is every 2-week treatment as opposed to every 8 weeks in the ravulizumab. They're all approved for acetylcholine receptor because that is the IgG1 that activates complement. The top are IV, and then zilucoplan is a subcutaneous. These are well-tolerated drugs, headaches, some increased risk of infection. The zilucoplan has associated injection site reactions. And then just threw in for space reasons, the rituximab at the bottom as a B-cell depleter. This has not been approved in myasthenia gravis, but in contrast, it has been used in both AChR and MuSK, and this is an every 6-month treatment infusion. So on to our neonatal FcRn inhibitors. So the neonatal crystallizable fragment receptor antagonists work by blocking this mechanism. This is in normal function, and the FcRn inhibitors, the FcRn, neonatal Fc receptors, will bind to IgG, and they're part of the mechanism that recycles our IgG. The problem with that is that IgG is bound to antibodies, the antibodies that I've been talking about. And what the FcRn inhibitors do is they prevent that recycling by blocking in the endosome the binding of the neonatal Fc receptor to the IgG, and therefore the unbound IgG is sent to be broken down in the lysosomes and discarded. So antibodies are not recycled. So the efgartigimod alpha is the first in this group of FcRn inhibitors. This is a phase 3 RCT. The majority of patients were AChR positive. Of 167 patients that were enrolled, 77% had AChR antibodies. The primary objective was the proportion of the AChR MG-ADL responders, and that was defined as a greater than 2-point improvement in MG-ADL score that was sustained for 4 weeks. So this treatment cycle is IV for 4 weeks, IV weekly times 4, and then a period of time off treatment. And if the patient worsened during that period of time, then that cycle could be repeated. The first treatment cycle saw that there was a 68% of individuals treated that reached this primary objective compared to only 30% of the placebo. There were a number of secondary objectives looking at the proportion of QMG responders, the percentage of MG-ADL responders, and also the time that responders were above 2-point difference. All of these met statistical significance. This is at 4 weeks down here, and we see the blue line is the treatment group, and all of the scales showed improvement, maximizing at about 4 to 5 weeks. And looking at the QMG score, there was a greater percentage of responders in the efgartigimod group. So this has been approved for MG treatment. The development of efgartigimod subcutaneous allows a shorter infusion time in the order of 90 seconds. This phase 3 randomized trial compared the subcutaneous version to the IV formulation. And the primary objective was simply the percent change in the baseline total IgG. That was met in the AChR positive individuals. The green line is the subcutaneous, and it maps well in correlation with the IV. There was a significant drop in both treatments for the AChR antibody value in the serum. And then this is also looking at some of the secondary objectives of the MG-ADL and the QMG responders and the mean change from baseline score for each of those. This is repeated cycles, and it demonstrates that with each cycle, there is a decrease in the MG-ADL score, the QMG at the bottom, as well as the looking at, the overall population, and then also just the purely AChR antibody positive. And this has also been approved for treatment. The rozanolixizumab is the agent that is similar. So this is also FcRn inhibitor, and this phase 3 trial looked at different doses, so 7 versus 10 milligrams per kilogram, and it's subcutaneous, and it's weekly for 6 weeks, then off cycle, and then it can be repeated. The primary objective here was a change in the MG-ADL score from baseline to day 43, and then an observation period. And there was an improvement in the MG-ADL score of 2.6 compared to the placebo group. There was also an improvement of more than 5 points in the MG composite score, and then also nearly 5 points in the QMG score. And interestingly, the MUS group, only 21 individuals, but they had a 7-point improvement in their MG-ADL score. And that was interestingly at the lower dose as opposed to the higher dose. and placebo group actually worsened, looking at that MuSK group specifically. Nipocalimab is our most recently approved agent and FcRn inhibitor. This phase 3 trial enrolled almost 200 individuals. Most of them were antibody positive. So now we're looking at some of the seronegative individuals with myasthenia gravis. The primary objective here was a change in the MG-ADL score from baseline to an average of the weeks 22 through 24, with the idea that MG-ADL scores can vary weekly, and taking the average of that. This was statistically significant with an improvement of 1.45 in the MG-ADL score compared to the placebo group. Also, looking at the individuals, the nipocalimab group is in blue, and 56% of individuals had a response compared to the baseline versus the average of the final weeks up to 24 weeks. And similarly, there was a difference between the amount of improvement that was seen. So these are the individuals that had more than a 50% improvement. Nipocalimab in pediatrics. This is a enrolling phase 2/3 open label study. 7 individuals were enrolled, and these were ages 12 to 17 with refractory generalized MG. And the primary outcome was looking at the effect on IgG, safety and tolerability, and PK. And the mean MG-ADL improvement, total score over that 24-week period, was 2.4 points, and the QMG score of 3.8 points. So our landscape of FcRn inhibitors. The efgartigimods are IgG fragment. This is approved both the IV and the subcutaneous. This is a weekly treatment, either IV or subcutaneously for 4 weeks, and then as clinically indicated is how it's approved. My experience has been individuals are looking at not waiting a full 4 weeks off of treatment. And I've been trying to shift them to the 4 weeks of treatment, 3 weeks off, if I can get it that way. These agents are well tolerated. There's a slight increased risk of infection reported in these. The rosanolixizumab is a monoclonal antibody. It's been approved both for AChR as well as MuSK, generalized MG, again, weekly times 6, off cycle for about 6 weeks, maybe a little bit earlier, and then retreatment for 6 weeks, and that cycle continues. Nipocalimab, the most recently approved in both adults and adolescents, a monoclonal antibody, and that is approved for both AChR as well as MuSK antibody positive generalized MG. And the dosing regimen is every other week. And again, these are fairly well tolerated. So I want to talk about a couple other phase 3 trials that may be exciting. The inebilizumab is a CD19 B cell depleter. The idea is your CD19 surface antigen marker B cells are probably longer lasting than your CD20, so you're going to get a greater population of the B cells. This looked at 238 individuals in this phase 3 RCT, generalized myasthenia gravis with acetylcholine receptor antibody positivity in 79%. The remainder were MuSK. And the treatment is 300 milligrams infused at day 1, day 15, and then again at day 183. And the primary endpoint here was change in MG-ADL score from baseline to 6 months. And in the treatment group, There was an improvement of 2 points in this score compared to the placebo group, and there was improvement also in the QMG score of 2.5 points at the end of the trial. This was fairly well tolerated. We await to see what the end result will be of this treatment, but I think that would be very exciting if we got something approved that only needed treatment every 6 months. Um, Satralizumab, I'll only mention as a different category, an IL-6 inhibitor. Um, because there was only an improvement of 1 point in the MG-ADL score and there were more side effects, the sponsor halted further development of this particular IL-6 inhibitor. And I'll talk about what my approach is in these individuals. I still use standard of care, which means individuals are coming in and I'm treating them initially when I'm strongly suspicious of the disease with pyridostigmine. This agent blocks acetylcholinesterase. It's effective within an hour. It lasts about 4 to 6 hours, and then individuals need retreatment. There are few side effects with it is uh, dose. You ask the individual, it's significant. So diarrhea can be a significant problem with this agent, but it's still the go-to starting point. Steroids are very effective, probably 90% response rate. What I'm doing now, as opposed to what I used to do, I'm using lower doses. I'll start with 20 milligrams a day. I'll do that for a week, in part because there can be a risk of worsening of symptoms in myasthenia gravis with starting this, and it's less with a lower dose. And then the second week, I'll look at kind of based on the severity and potential side effects of increasing to what is more now my full dose of 60 milligrams a day, and um, uh, kind of follow them over time. Response to steroids, about 10 to 30 days. So it's still an earlier response than some of the other agents. The azathioprine and mycophenolate, I have, great comfort with. I've used them for decades. And these I will overlap with the prednisone because it takes about 3 to 6 months to get really a full effect from these agents, and the monitoring is required for these blood count and for azathioprine liver function. Thymectomy, I still recommend for individuals less than 65, consistent with the trial. The benefit is probably long-term in the trial. It was seen to decrease the amount of prednisone required within 6 months, um, was the starting trend, and then definitely by 12 months. The use of immune modulatory agents like IVIG and Plex has some role clearly in exacerbations, those that require hospitalizations. Trials of IVIG in an ongoing basis of myasthenia gravis did not show the ability to reduce the prednisone dose. Plex is complicated. You need a central line. You need a location that can do it. So those I don't typically use on an ongoing basis, but those historically have been our go-to agents before all these newer medications were approved. And then a lot because of insurance, partly cost, I look at the FcRn inhibitors, so that's the efgartigimod, which is Vyvgart, our nipocalimab, and then the uh, um, rozanolixizumab. Those agents have been somewhat easier to approve, I think, in part related to cost. Complement inhibitors certainly have their place. Part of it is that if I'm thinking about them, I'm getting the individual lined up to get those vaccinations, and that unfortunately takes a bit of effort. Sometimes pharmacies won't give the vaccinations, so we've had to try to work around that. Um, I would really advocate for clinical trials. As you'll see, there are a lot coming, and that's how we figure out how we can help patients get better in this disease. Lastly, I have to put a plug in for exercise. I've seen so many individuals that have been hospitalized and they're weak, they're deconditioned. We worry about exercise worsening the symptoms, but it's a good place to start and remind them that they can do it. And individuals with myasthenia gravis can have a regular, full exercise regimen. And I will mention a few things about newer uh, myasthenia gravis situations. And that's in immune checkpoint inhibitors. And I've seen this with pembrolizumab a couple times, or the combination of the pembro with the nivolumab. These are the PD-1 anti-programmed cell death ICIs. In myasthenia gravis, this is data from MD Anderson, and they found that in 65 individuals, they were older age. These are individuals with refractory cancers, and so melanomas, lung cancers, small squamous cell cancer, and renal cell carcinoma. The individuals that I saw had prostate cancer, and the majority of these were the anti-PD-1. The median time to onset was about 4 weeks. With the ICI-induced MG, there's also a significant overlap of about a third with myositis, and in a number of cases, there's also myocarditis. Respiratory failure was seen in about 50%, death in about a third, and those are much higher values than we see in myasthenia gravis. Steroids improved individuals by about in 60% of individuals, and there was a series that found that almost 20% of individuals got complete resolution of their generalized MG, which has not been my experience. In this series, 26% worsened and 55% improved. There was a better outcome with IVIG or Plex as a first-line therapy in 96% compared to just steroids alone. And so the 2020 consensus statement on myasthenia gravis treatment regarding these immune checkpoint inhibitors found that pre-existing MG was not an absolute contraindication. It's important to avoid combination ICIs. Individuals need close monitoring of respiratory and bulbar function. Standard MG treatment should be continued through the treatment, and early aggressive treatment with high-dose steroids combined with plasma exchange or IVIG is indicated, and potentially withdrawing the immune checkpoint inhibitors. The two cases I saw, one was an 83-year-old gentleman with metastatic cancer to the brain, and he had ptosis and double vision, and he responded to therapy. He had both AChR antibodies and an elevated CK, and his EMG showed both a myopathy as well as the myasthenia gravis. Um, Unfortunately, they do succumb to other complications from their disease. And then finally, considerations and future directions. So, what challenges do we still face despite all of these new agents being approved? So, access. So, patients that are underinsured, uninsured, are not likely to be able to get these treatments, at least not easily. There are still significant gaps in care. So, none of these looked at ocular MG, and that's about 20% of the population have purely ocular MG, and that can be pretty disabling with constant double vision. Pregnant individuals are not included, and MuSK antibody, LRP4 antibody, although a small population, those are not addressed in at least the historical trials I presented. Cost and placebo response are interesting conundra. So, cost comparison with brand names listed. If we're looking at the top, these are our complement inhibitors, and we're looking at $500,000 to $600,000 per year. These are indicated for the AChR, contrasting that with rituximab, IVIG, and sub-QIG that may fall in less than $100,000 per year. And lastly, at the bottom are our FcRn inhibitors, and those are maybe falling in around 300,000. It's difficult to get really exact numbers, but just gives you a rough sense of cost of these agents. The benefit is they're pretty well tolerated. Patients like fewer side effects, and there's less monitoring required with a number of these. Looking a little bit at placebo response, I started thinking about this years ago when the ICE trial came out for CIDP, and there was like a 23% placebo response for IVIG. Couldn't believe it. Well, this slide, I tried to put together a little bit of a sense of um, what where we see a placebo response. You can't really compare these trials head to head because different durations, looking at different primary endpoints, different requirements for enrollment. But for example, even what was considered significant, so for eculizumab, a 3-point improvement in the MG-ADL compared to the other trials that looked more like at a 2-point improvement. If we look at drug compared to placebo response rate, the numbers are surprisingly similar. And this isn't necessarily fair to compare because these are mean improvements, but it gives you a sense of some the difficulty in finding a significant value when you have people with myasthenia gravis that may have really variable presentations. For all of these agents, the placebo response was present. And then in the last column here, I included the change in the MG-ADL. It wasn't obvious in all of them, and based on different trial designs was hard to get at. And can we really compare these? I don't know, but I put them up there, looking at how much improvement was seen in the MG-ADL score. So, what are we excited about? So, for the future, we have a lot of potential targets in MG therapies, looking at how do we alter T cell function, B cell function, getting at the IgG, complement inhibitors, and newer ideas, as you'll see, looking at CAR T cell therapy and MG and other autoimmune disorders. The current phase 3 trials, I've already mentioned a couple of these, but looking at altering T cell function and B cell function, we're currently enrolling for the BTK inhibitor, remibrutinib, that is um, an oral agent, and in generalized MG and individuals that are antibody positive but also antibody negative. There are a number of additional complement inhibitors. We will be starting, Mike Weiss in January, will be starting the RNA CAR T cells. So not looking at worrying about CRS response in these individuals. And that's against a B cell maturation agent. Um, and this I added inappropriately. It's not phase 3 trial. Um, so also clinical phase 1, 2 trials that are available. There are a number of CAR T cell therapies looking at getting at that CD19. And Dr. Edmondson is enrolling both for 2 of the CAR T cell therapies with CABA and with BMS. We have some other agents that are aiming at complement inhibitors, chloride channel inhibitors, and then also more complicated block in a polymer matrix. And we now also are looking at an agent that's a complement inhibitor in individuals that have purely ocular. So there's a lot more to come. These are my references. And I thank you for your attention, and I'm happy to take questions as time allows.
Thank you so much. That was a really fantastic overview of a really increasingly complicated landscape. I really particularly appreciated hearing your take on how you start these therapies and the role that each of them has sort of in your clinical practice, because it gets quite complicated. So if anyone has questions, please feel free to enter those in the Q&A. I had actually one to start, if that's all right. And, it comes from the data that you presented around the B cell inhibition and rituximab. I think the first B cell trial that you presented, the RhinoMax study, where they treated with the low dose rituximab sort of in patients who are recently diagnosed. Um, do you think that we should be using more B cell inhibition early in myasthenia therapy? I think, a lot of us, at least in my practice, partly because there's not a label for it, oftentimes we'll use it more in sort of more severe, more refractory patients, especially now that we have a whole bunch of other agents that have a label, a FDA indication for myasthenia gravis. Where does the B cell inhibition with rituximab fall in your practice? Is it something you think we as a field should be doing more of? I ask partly because we may be seeing an approval for a CD19 inhibitor in the coming year or so in this
Yeah.
space.
Yeah. So the I keep talking about rituximab. It,
Mhm,
it has been the go-to for years in individuals that were refractory in MG and in other autoimmune disorders. And um, it the talking about it has been somewhat disappointing, but the difficulty is we don't have a new agent, we don't have a new indication. Rituximab is now generic, available
mhm,
in multiple forms. So I am really excited about B cell therapy. If we could do it, and partly based on the inebilizumab,
mhm,
looking at depleting maybe CD19, at least theoretically, and CD20 cells. I would love to use it earlier. I don't know how that would be possible.
mhm.
I still have trouble getting it approved in refractory MG, despite a much lower cost.
Yeah, yeah, I've run into the same issue
Uh,
where it's a challenge to get things approved, even when $20,000 infusion versus 500,000 a year. You'd think they would go for, but
yeah.
Mike Elliott actually has a question in the chat about what your sort of best recommendations or suggestions are for treating seronegative patients with MG.
Yeah, it's that's challenging. There's these are the people that are left out in addition to I mentioned ocular, and I still have used my standard of care approach. I've still used the um, steroids and Cellcept and the Imuran, the azathioprine. Um, my next go-to in these cases is not going to be complement inhibitors because they're not. Um, I don't know. They're not necessarily going to work. And so, my recommendation there isn't really very different than individuals that have antibody positive MG. And we're seeing more of these individuals enrolled in these trials. And so maybe there will be more forthcoming. But I still use the same approach that I described for generalized MG that is antibody positive.
Great. So it sounds like pretty similar approach other than maybe excluding the C5 inhibitors from that algorithm for the seronegative patients. Yeah,
Potentially without having a better sense of what the mechanism is there.
yeah, yeah. So another question from Bonnie Kyung, who's one of our neuro-ophthalmologists, who's asking what is the potential pathway needed to get newer drugs FDA approved for ocular myasthenia gravis? And are there clinical trials that are being considered for use in ocular myasthenia?
Yes, we are currently working on um, getting a newer agent that is this is from Argenx, and they are looking at a complement inhibitor in purely ocular. And so it probably is going to be at least 6 months before that trial is up and running. Um, Efgartigimod has looked at every angle of this. So not only do they have a sub-Q version available, which is a much faster infusion rate, but they're also looking at it in multiple different diseases. They have included seronegative patients also. And unfortunately, we don't have great data so far. But what I see following suit is I think these companies are gonna continue to look for other indications, and so we finally are seeing that the purely ocular are going to be addressed.
Right. And then another question for Mike Doherty, who's one of our epileptologists, who's wondering about potential downsides of thymectomy on immune responses, not just autoimmune mitigation, which is a sort of interesting question that we've been dealing with in the field around if there are sort of downstream effects from thymectomy or negative sequelae, other than just potentially mitigating the severity of myasthenia.
Yeah, I would have to answer that in that I haven't seen that. And if we look at thymoma is a little bit different, but patients that really, really, really should have that mass removed, um, downstream, I really haven't seen much. And the thymus gland, although it has a role because it does trigger these B cell responses and antibody production, it really atrophies. And part of the reason why they didn't enroll people over age 65, it just really isn't active at that point. So nothing that I'm aware of in the thymectomy in these individuals. And my experience in these people I followed over time. I didn't mention there's some patients that respond to treatment. Most people get thymectomy and have I've gotten off of drug and they have not had a recurrence. So that's also part of myasthenia.
Yeah, sort of a follow-on question for that, partly because, we haven't had updated international consensus guidelines in a few years now, is what is the age range that you're sort of considering thymectomy in clinical practice? Do you cut off at 50, at 60? If someone's healthy and much older, do you still offer them a thymectomy? Obviously, in sort of generalized antibody positive myasthenia.
Well, because after age 65, so the trial only looked at individuals up to age 65 with the idea that it's probably not much active beyond that. And then we're looking at more comorbidities with age. So I don't typically recommend it in individuals that don't have a thymoma that are over age 65.
Mhm. Great. And then one last question from Dr. Ivanek, who's one of our other neuromuscular specialists. I was wondering if you could comment on fatigue in myasthenia gravis. Sometimes we struggle with patients who seem to be well controlled in terms of other symptoms, but have this very persistent fatigue, and wondering if you have an approach for addressing this.
Um, I don't have an effective approach. Uh, there's fatigue and then there's fatigable weakness, and where the two separate is very unclear, particularly for patients with that complaint.
Mhm.
And the obvious is I look at what else is going on in their life, their medications, and also are they sleeping? Those are my first two
Mhm.
medications. Um, use of I don't use the amphetamines in these situations, and I don't partly I don't really want to manage that, but
Mhm.
trying modafinil in addition to looking at those other factors, I haven't had much success with that. Um, so I wish I had a better answer. This was looked at in these trials also because they looked at quality of life, and that's in there. Um, but I wish I had a better answer than that.
Right. No, I think that's great. It's helpful to think about those other components of things that could be contributing to fatigue. And then I think just one more question before we wrap up from Dr. Rapovic, who's one of our MS specialist neuroimmunologists. And he makes a comment that as a disease with a known molecular autoimmune target, MG could be a disease to consider for sort of tolerization studies, and whether that approach, essentially reverse vaccination, could be viable.
So, to be clear on this, this would be looking at a vaccination against the antibodies.
So I'm not sure, and maybe Dr. Povic, if you're able to, I think you're on the panelist, you could chime in here to
Sure.
clarify further.
Yeah, I'd be happy to. This is the idea, I think, from Larry Steinman at Stanford for diabetes type 1 and diseases like myasthenia, where we know the target. So if the body is driving this autoimmune response, um, would we be able to polarize the body to induce tolerance and somehow fundamentally prevent that autoimmunity at its root by what's known as reverse vaccination, tolerizing the host so that they don't generate that autoimmune response. That's very challenging to do in a disease like MS that I treat, where we don't have a clear target. But in some types of myasthenia, it, in theory, should be possible.
Yeah, great question. In and thinking about the uh, how what this approach would be, and that would be um, I'm trying to wrap my head around this and thinking about is, like with allergies, like do we take a little tiny molecule and then we expose the individual to it,
Hmm.
and then we just keep exposing to higher levels.
Hmm.
But I think that is not exactly what this is.
Mhm.
So I don't have an answer for you, and I'm happy to look into that further if we have any information out there on this particular approach. And you'd have to know which antibody they had, and I don't know how it would work for the seronegative
Yeah,
group. So I'm sorry I don't have a better answer for you than that.
yeah. That's a really interesting idea. It's not one I've heard sort of bandied around at meetings or advisory boards to date, but we have our upcoming ANEM meeting in San Francisco. It'd be interesting to see if that's coming up or to ask other folks who are sort of in the in the thick of a lot of the basic science, whether that's
Yes.
an approach that's been looked at. Great. Well, thank you so much for a fantastic presentation and for engaging and answering all of the questions for us today. Really appreciate your time. And I also, before I forget, I do want to take a moment to thank the sponsor of today's Grand Rounds, which is UCB. And thank you, everyone, for your attendance today and for the great questions.
Great. Thank you. Good to see you, Kristen, and thank you, everybody. It's nice hearing old friends' names too.
Thank you, Jane.
Take care.